Hello, everyone. Good afternoon, good morning, good evening. Welcome to our session that is hosted by the Learning Network for Countries in Transition, or LINKed as we call it, to discuss the question, should public health programs be integrated into national health insurance? So I think we'll have a wonderful discussion today. My name is Cheryl Cashin. I'll be the moderator for today's session. I'm a managing director in the global health practice at Results for Development. And I would like to also introduce our distinguished panel that will share some very interesting country experience with us today to delve more deeply into this question. We'll hear first from Dr. Tamara Kabunia, who is the first Deputy Minister of Health in the Republic of Georgia, and Dr. Koku Owanar, who is former Director of Policy, Planning, Monitoring, and Evaluation Division of the Ghana Health Service, and Dr. Asik Surya, who is Head of Immunization Subdirectorate and the EPI Manager in Indonesia. So for today's session, I'll start by just giving a few framing slides to provide an overview of how we are looking at this question. And then we will hear from each of our panelists to look at what their experience has been in their countries addressing this issue. So if I could have the next slide, please. So I wanted to really start by framing our question in the broader framework of universal health coverage. And this is really the ultimate goal, is to make sure that healthy lives and well-being is promoted for all people at all ages, as is specified in SDG number 3. In that SDG, there is a target that very explicitly embodies the notion of universal health coverage, providing coverage of essential services, including immunization and financial risk protection from the occurrence of economically burdensome healthcare costs. So this is our framing, this is our ultimate goal. And when we talk about this discussion today about specifically health services that have a public health component, and more specifically immunization, how to ensure these goals are met for immunization. Maybe the next piece of the slide, please. So as we speak today, we're going to be keeping in our minds these ultimate goals that are embodied in this SDG target for universal health coverage, and these goals of equity, quality of services, and financial protection. So as people access immunization services, ensuring that equity, good quality, and financial protection are also in place. Next slide, please. So the way we want to frame this is that in order to achieve universal health coverage, all health systems have to carry out certain functions. And these functions, to work well, can be organized in different ways in different country contexts. But all of these systems need to, first of all, raise revenue, bring money into the health system through different mechanisms, from taxes or premiums for health insurance or other kinds of contributions. So getting the revenues raised. But then there's a very important function of pooling these revenues. And pooling in health is very important because that's where we get equity, that people pay into the pool for health coverage based on their ability to pay if the system is working well. And they are receiving benefits out of the pool based on their need. So this helps us achieve equity and also protect people against the risk of the uncertain events that are associated with high healthcare costs and high health needs. And then there's a function of taking that money from the pool and actually purchasing the services from healthcare providers. And then ultimately, of course, the provision of services. So we're looking at all of these functions and how they can be organized in the system, and then what that means for immunization services. Next slide, please. So when we talk about national health insurance, it is really just one way of organizing these functions. It's one possible way, and there are others. But in this way, we look at how revenues are raised, and that is typically through some kind of a dedicated funding stream. It might be a dedicated tax or specified transfers of general revenues for national health insurance purposes, or premium contributions by individuals, but it's more of a dedicated stream of funds for this purpose. And then these funds are typically pooled in some agency, either within a Ministry of Health or a separate agency, but there is some agency that has the responsibility for managing this pool and to ensure that the entitled population receives the benefits that are explicitly identified. And this is another way that national health insurance is a bit distinguished from other ways of organizing these functions, and that is that people are covered or enter into the pool because they're entitled to. Either they have made a contribution, or the government or some other entity has made a contribution on their behalf. And the benefits that they're entitled to receive are also specified clearly, hopefully. And then in terms of purchasing, in national health insurance systems, there is a more explicit contracting mechanism, typically, an agreement between this agency and providers. And there is usually some multiple ways of paying these providers for these services that go beyond traditional budgets, but more closely link payment to the actual services in some way. And then finally, in the provision of services, it might be some combination of public and private providers. And just I think as we listen to our country experience today, it's important to remember that these national health insurance systems often exist in parallel with other arrangements for financing health services, often supply side financing from the budget. Next slide, please. So why would countries choose this way of organizing the functions for universal health coverage? What benefits do they hope to achieve? And often there is a hope that this dedicated funding stream that is often linked to national health insurance are protected. They are going to ensure adequate funding for this, that this dedicated funding source will increase overall resources available for universal health coverage. There's also some hope or objective that by clearly specifying the benefits and the entitlements, that these services will be prioritized and people will be more likely to be able to access them. And there are also some objectives that are related to using this power of a purchasing agency and new ways of paying providers for services through this split between a purchasing agency and the providers that might create some incentives for efficiency and quality and more flexibility in how funds are used. But in fact, not all of these objectives are always met in practice, and we've listed some challenges that we often see in practice on the slide. And so whether or not these benefits are achieved depend on a lot of factors in the context. And so when we look at immunization, we're also thinking about these objectives that might be in place for integrating immunization into national health insurance. So will it increase the funding available? Will it create the right incentives for efficiency and quality and access? Will funds be able to be used flexibly to get to where they're needed most? And these are some of the questions that we'll explore in the country experience that we'll hear from our panelists. Next slide, please. So as we think about the question that we've posed in this session, so should these public health services or services that have a public health component be integrated into national health insurance systems? And this deserves some very special consideration because of this unique characteristic that services such as immunization have both a public health and an individual health service component. So by immunizing an individual, there are also protective benefits for others beyond that individual. And so how does that get factored in the financing and service delivery? And does that get adequately accounted for if these services are integrated into a national health insurance system? And then of course, there's the individual piece, which is more traditional for health services, that you are, as an individual, you seek care, you get the benefit of that care. And there is also a component of that in these kinds of services and immunization in particular. Next slide, please. So just to quickly, again, setting the stage, what does it mean then with this framework to integrate immunization into national health insurance? So in this case, it means that some of the dedicated funding for the national health insurance system is going to be allocated to immunization services. It means that immunization is specified as an entitlement in the benefit package in this pool of funds. That providers are paid for immunization services through the contracting mechanisms and through the payment systems that are used by the National Health Insurance Agency. And that often both public and private providers are contracted to deliver immunization services. Next slide, please. And just to give a picture of what this looks like, remembering that there are other financing sources often also in place, especially for immunization. Other parts of the program that might not be included in the benefits package, for example. And so you have this mix of institutional arrangements and fund flows that can be leveraged to get better access, quality, and efficiency for services, or there are also some risks that the public health functions might not be adequately funded. So these are some of the issues that we want to look more deeply at today. Next slide, please. And so finally, just to set up our discussion, we want to look at this question of whether or not to integrate public health services such as immunization into national health insurance, both from the side of the opportunities that this might create, as well as some of the challenges and risks. So the opportunities may be that access to immunization is made explicit, that there is more dedicated funding available, and there might be good incentives through new provider payment systems that can increase access, quality, and efficiency. But there are potential challenges and risks. So if national health insurance is not universally covering everyone, then there's the question of how those who are not covered get access to services and with financial protection for immunization. If there are multiple funding sources, if national health insurance exists together with other financing arrangements, there might be some confusion or lack of understanding about entitlements, who is entitled to get what and for what payment. And if these other services that are in national health insurance the curative services are paid in a way that might be more attractive to providers, will that crowd out immunization services that might be paid at a lower rate because of the preventive nature of it? And then finally, if vaccines are included, immunizations included in the benefits package, and new vaccines come along, will this agency want to bear the financial responsibility for adding vaccines to the schedule and then having the responsibility for covering them? So these are the questions, the opportunities and challenges. And just to set up our discussion today, my final slide. Just some questions for us all to be thinking about that I think some of our panelists will hit on. How do countries leverage the opportunities of including immunization in national health insurance and minimize these challenges and risks? What are the pros and cons of integrating other parts of immunization into national health insurance, including vaccine procurement and other parts of the public health services that come with immunization? And then what are the best ways to finance and deliver all of this package, the public and personal health services in a national health insurance system? So that is all in the way of setting up and framing our discussion today. And I'm very excited now to turn it over to our panelists. So first, I would like to ask Dr. Gabunia from Georgia to share your experience.
Thank you. It's really great to have the chance to share Georgia experience on integration of immunization services into the universal healthcare program. Georgia is a small country with 3.7 million population, and we have a universal healthcare program launched back in 2013. So this is not an insurance-based system, but this is the program in which the state procurement agency, National Health Agency, procures services directly from healthcare providers. Next slide, please. And the program provides universal access to primary care services for the entire population. Of course, it also entails some benefits for secondary care services, but for this particular presentation, I will describe how primary care services are organized to ensure a good coverage and provide adequate immunization services all over the country, including rural and urban areas. Services provided by a family physician and a nurse are covered by capitation payment in urban areas, and we have slightly different payment mechanism in rural areas, and this is fixed salary payment. It's well defined in the legal framework for the program what should be provided by primary care providers, and primary care providers' responsibilities include child health surveillance, immunization counseling, and also providing immunization services. All these are part of the primary care service package, and population is well aware that they should receive these services from the primary care providers. The National Center for Disease Control and Public Health is the agency responsible for providing and implementing immunization-related activities, and the center monitors implementation of the immunization programs to ensure adequate coverage. Next slide, please. So the key features of the immunization program in Georgia is that the services are fully integrated within UHC Village Doctors Program. This is about financial integration because services are covered through capitation payment and fixed salaries, as I've already mentioned. And financing for immunization fully comes from the state budget. After graduating from Gavi in 2019, immunization services now are a responsibility of the government, and all services, including service delivery as well as procuring vaccines and training of healthcare providers is covered by the state. All vaccinations and immunizations included in the national vaccination calendar are free for the population. Vaccines are purchased centrally to guarantee their quality and safety, and the National Center for Disease Control and Public Health is responsible for adequate supply chain management. And we have information management system to support adequate reporting and to ensure quality of data. And again, National Center for Public Health, National Center for Disease Control and Public Health is responsible agency to run the information management system for the immunization programs. Next slide, please. Here I presented institutional framework for implementing the immunization program, so you can see all agencies and players, and you can also see their responsibilities, starting from the Ministry of Health. Of course, the ministry is the main agency responsible for developing universal healthcare policies as well as designing immunization program, and then the ministry provides high-level oversight to ensure that we have adequate coverage and quality of vaccines and service delivery is adequate, and we have results also, results in terms of avoiding spread of infectious diseases, and we have National Technical Advisory Group established at the ministry. The group is composed of national clinical experts, and the ministry gets advice from this particular group on immunization related issues. This could relate to introducing new vaccines or changing immunization calendar or following new recommendations issued by UNICEF, the World Health Organization, Gavi, or other international partners. Then we have implementers, and the main implementing body agency, as I mentioned, the National Center for Disease Control and Public Health. This is the agency responsible for implementing immunization programs. And these responsibilities include procuring vaccines, distributing vaccines via cold chain, as well as monitoring implementation of the immunization program at a provider level. We have primary care providers delivering immunization services. So the key feature of the Georgian healthcare system is that over 85% of healthcare providers are private. So we have public and private providers engaged in delivering immunization services, and this happens through universal healthcare program. Public health units, which are at each district level in Georgia, they are in charge for health education, as well as they cooperate with the primary healthcare providers, and they are involved in cold chain, and they play some role in distributing vaccines and delivering vaccines to primary care providers and helping them with supply management. Hospitals are also engaged in vaccination services, and we have this special list for hospitals, which vaccine should be delivered at a hospital level, and these are also public and private hospitals all engaged in immunization services. And then we have National Health Agency, which is the main purchasing agency, and the agency is purchasing services within the Universal Healthcare Program. So in terms of procuring the vaccines, we have the National Center for Disease Control and Public Health responsible for bringing vaccines into the country, and then we have National Health Agency purchasing health services and making sure that healthcare providers are in place and they deliver adequate services for the population. Next slide, please. Of course, integration of immunization into the UHC program has quite clear benefits, and we see that integration helps a lot to generate community demand by having family physicians directly providing health education and immunization counseling. Using PHC services as a platform for immunization is less costly and improves continuity of care among healthcare providers and families. Immunization visits can be used as an opportunity for addressing other health problems among patients and their family members, which is also very important. And we clearly see that sometimes immunization visits are used as an opportunity for addressing chronic conditions, as well as having communication with family members and providing like counseling for mothers during pregnancy and many other conditions. And of course, integration allows us to reduce geographic access barriers and allows for improving coverage because we have quite good access to primary care services across the country. Next slide, please. Of course, there are some challenges, and we do realize that the immunization may not be the top priority for private providers as well as hospitals, which have many competing programs going on, and they need to address everyone's need by implementing those programs. However, we see that for immunization, it's very important to have good linkages in between public health providers and primary care workers. It's important to establish some to establish adequate understanding of how important the immunization is, and to engage private providers more actively in delivering immunization services to their catchment population. We also see that lack of incentives is a challenge, and we do not have right now, for the moment, we do not have any immunization performance related incentives for private providers. So this is something that we need to explore more to understand whether or not introducing performance-related payment could help us to improve immunization coverage. And then it's again difficult for primary care providers to maintain uninterrupted delivery of immunization services during the pandemic, as primary care providers are overburdened with COVID-related responsibilities. So nowadays, we are concerned with the COVID pandemic, but this could be any other epidemic which may overburden primary care providers. And that's why, again, it's very important to have public health services, again, mobilized to make sure that they can take over some responsibilities if primary care providers fail to meet immunization related responsibilities and fully accomplish their tasks. This is briefly what I wanted to share today, and of course I would be more than happy to address your questions and provide additional clarification as needed. Thank you for your attention. Cheryl, over to you.
Thank you so much, Tamara. This was such a great example of looking at how Georgia has organized the different functions appropriate for your context to try to make the best balance. And I think this idea of not linking the coverage to entitlement, but it's free for everyone is in your UHC program, that avoids that problem of some people being covered and others not being covered, and therefore not maybe having access to immunization. So taking advantage of that, while at the same time taking advantage of a purchasing agency to try to use contracting and provider payment. I think the challenge that you shared about making it kind of attractive for private providers to engage and private providers to contract with the purchasing agency is a challenge that a lot of countries face, and hopefully we'll get some additional insights from other panelists there as well. I'd like to turn now to Ghana. Dr. Awanor, if you could please share your experience in Ghana with integrating or not immunization into the national health insurance system.
Thank you very much, Cheryl, for the opportunity, and hello to all the panelists and the participants for this session. Next slide. So want to look at the case of Ghana. We already know that for global EPI was launched in 1974 by WHO, and the opportunity that this provides to promote integrated services across different continents and countries is quite significant. We are also aware of the interventions in terms of how lives are saved in millions. So EPI is very important, immunization is very important. In Ghana, we started our first EPI program in 1978 with 6 vaccines. In 1992, we introduced additional 1, yellow fever. In 2002, we added 2 more. In 2012, we added 2. And then in 2013, we added 1. And as at now, from 2016, we are delivering a total of 13 immunization or vaccines every year. So that is quite enormous. There are steps again to add, additional ones, and that is being considered based on the evidence that we have in the use of those additional vaccinations. Next. But to link this to our national health insurance, and the question is whether our immunization services are being funded under our national health insurance program. Just a little bit of history in terms of our health financing reform as far as our health system is concerned. So in 1957, we have a free health care policy implemented. That went on for a couple of years. In 1970, this 57 was just around, the time that we had our independence as a country. Ghana is a country of now currently about 32 million population. In 1970, we experienced some economic shocks and what we call the structural adjustment program, and therefore we had to pay for services. So nominal payments were introduced for health services. But in 1985, as things got worse, we introduced what is called the cash and carry, meaning that there might be full payment by clients or for service that they are receiving. In actual fact, this policy excluded majority of the people to access healthcare because of high levels of poverty. In the 1990s were where we started to explore the possibilities of national health insurance. We started with what we call community-based mutual health insurance. And then in 2000, we realized there was high out-of-pocket expenditure on health. And then, of course, there were low utilization. And in 2003, we introduced the national health insurance. So we are talking about implementing experience of over almost 17 years now. Next slide. Now, our national health insurance, people always say that it's so liberal because it covers over 95% of our disease condition in Ghana. OPD services, inpatient services, oral health, maternity care, eye care, dental care, emergency care. However, in the benefit package, there are some exclusions. Those exclusions are, for instance, immunization is one of them, even though the part of government funding comes in supporting the procurement of vaccines. And then other services like cosmetic surgery, etc., are excluded in the our national health insurance benefit package. And that is very important to take note of. Next, please. Now, there are public health essentials of immunization and national health insurance. For us, immunization provides opportunity for a lot more advocacy, brings about social and community mobilization because of the processes that people go through to be able to to provide these services, and create a lot of partnership and stimulate community engagement. Then also is also the whole thing that we do about health education, health communication, health promotion that result in behavior change communication. The positive influence of practice, attitude, and behavior in communities through the use of or the implementation of our EPI or immunization programs. Now, however, the challenge that we have is with NHIA, if you relate that to immunization and the whole PPI program, there is absence of the declared financial mechanism for public health intervention within the National Health Insurance Act in Ghana. What that means is that our National Health Insurance basically is concentrated on clinical services, okay? It does not pay for public health services. We also know that for immunization, definitely when people when the staff are going to provide the services, even though clients do not directly pay for the services, there are additional costs of outreach services, transportation, logistics, mobilization. Those costs are not part of the National Health Insurance. We thought that integrated service of health service could be a pathway both between the clinical and the public health services to drive, the services in a way that will provide the maximum benefit to the population. As I said, there's lack of focus on NCDs, and therefore the same way that NHIA, that our national insurance does not pay for immunization, that also does not pay for, national non-communicable diseases. We thought that this could also, national insurance could be a way to strengthen our surveillance system through the vaccination in terms of preventable diseases. Next slide, please. So I just tried to provide you, I was trying to look at what has been the coverage in terms of looking at the historical data of our immunization services prior to introduction of NHIA, and how have we fared. On the left side, basically, is our DIMS2 data, because we started collecting immunization data in our DIMS from 2012. So you could see how our BCG has performed over the years. Of course, this is all during the introduction or after the introduction of NHIA. And one would have expected probably if we had been funding our NHIA through our NHIA funds, probably we'll have a higher coverage. You could see how we are doing for tetanus, diphtheria 2. You can see how we are doing for Penta. And then the right side was just trying to look at the legacy data using WHO, UNICEF estimates as provided. So yes, you could make some you could draw some conclusions whether funding NHIA with immunization could have provided a better and further better benefits to the population and in terms of the coverage. Next slide. So let me just say that if you look at our funding, I think we need to, I think Ghana, as I listened to the presentation by the minister from Georgia, I think we have quite some lessons to learn. Interesting to know that Georgia has graduated and now funding the immunization 100% from national budget. Ghana is in the process of beginning graduation. So we need to also know what to do in terms of funding. Currently, we have various sources of funding for our vaccines. The government of Ghana supply in terms of, if you talk about human resource infrastructure, yes, that's government responsibility. But we also have other partners and donors. UNICEF supports in terms of equipment, in terms of supply and delivery. We have WHO that provides a lot of technical assistance to developing our guidelines and etc. But the major support comes from Gavi that support the procurement of vaccines. And as I said, once we are into graduation or we are in the process of graduating, then we need to start thinking what happens to this support, particularly from Gavi in terms of procurement of vaccines. Next slide. So I try to think through what will be the likely challenges of our immunization program with currently without the NHI support or in terms of funding for NHI. Obviously, if you look at the graph I showed earlier, one would have thought that, you know, these low coverages could be a result of the fact that there had not been much funding for immunization. Not to even talk about the quality of EPI services in terms of storage of vaccines, in terms of transportation, in terms of the cold chain equipment, all that. How do we fund that? I mean, without funding through the NHIA. And then, of course, I said already that lack of dedicated funding to, you know, would be is detriment because we would have had increased immunization services and supplies of logistics. Of course, once we are not getting funding from NHI for immunization services, there's a likelihood that, you know, we will not be able to catch the majority of all the children, and therefore certain communities can be left out. Those communities are hard to reach. How do we get resources to be able to mobilize outreach services or vaccination programs in those areas? And of course, because of poor funding for you know, logistics supply, of course, then you might also have heading to quite a high dropout rate in terms of recovery. Next slide, please. So in conclusion, I think that we need to start working on ways that we are finding means to increase funding to immunization. Okay, we need a whole reform in our NHI structure. The Act basically is focusing on what? Clinical services. We need to move away from that and see how do we integrate, you know, public health services in the NHI funding. We need to look at other options and innovations. There are networks. The preferred provider partnership network is a model that has been tested, and I think these are ways that we can use to be able to improve service delivery. Strengthening domestic funding for API services is critical. We think that apart from government funding or apart from NHI, there must be a way that we are also mobilizing resources domestically to be able to add to that. And of course, prioritizing integrating public health services with NHIs. I'm so happy to see, again, one of the examples of how there's a disconnect between immunization programs or public health services and clinical services, and that needs to be addressed. And I think that finally, I think that immunization should be seen as a public good, and therefore we need to do a lot of advocacy, you know, in terms of getting the policymakers, the decision makers to know, or government, Minister of Finance to know, Minister of Health to know, so that in the long run they can allocate more funding through the NHI and include that as part of the package for funding and for service delivery. So that is what I can share with you for now in terms of immunization services and also NHI from the Ghana perspective. Thank you very much.
Thank you so much, Koko. That is really, Ghana's experience really highlights the challenges that arise when you keep separate these financing arrangements for preventive and public health services versus curative and clinical services. So I think I'll come back to you later in the Q&A and probe on that a bit more. I'd like to now turn it over to Dr. Surya and to hear Indonesia's experience integrating immunization into the national health insurance system there.
Thank you, Cheryl. Good evening. It is an honor for us to attend this symposium and together with our colleagues. And we are delighted to present about the Indonesian National Health Insurance and how it contributes to immunization services delivery. So next slide. National Health Insurance is part of the Indonesian National Social Security System that aims to attain the universal health coverage for the nation. Thus, it's mandatory for every citizen to be enrolled in the program. The benefit cover comprehensive package health services that included promotive, preventive, curative, rehabilitative, and of course, as well as the pharmaceutical and associated medical devices. National health insurance was first introduced in Indonesia in 2014 with the Social Security Administration for Health, we call here the BPJS, appointed as the implementing agency. Initially, it was expected that all citizens would have been covered under national health insurance in 2019. But the target was not achieved. However, the membership of the national health insurance has increased dramatically from 133 million, or about the 50% in 2014, to move that then more than 82% in 2020. With the current total membership more than 220 million. And this is updated the figures so that the slide and the national health insurance, primary health care play an extremely important role as the gatekeeper. The backbone of the Indonesian primary health care lay on the puskesmas, primary health care, a state-owned health facility at the sub-district level that provide first-line health care to the most citizens. The private public health clinic and GP's practices are also thriving in national health insurance, and their member keep increasing from time to time. As we can see here in the slide, despite the national health insurance increased the members cover, the ratio of the national health insurance contracted primary health care per insured member has decreased. And in terms of the public and private health provider, the current ratio is quite balanced within the two puskesmas. Still constitute the largest share of the BPJS or national insurance contracted primary care facility, more than 10,000 health center, followed by the private clinic and GP practitioner, comprising around the 6,000 and 5,000 respectively. All the primary care facility contracted by the national health insurance receive capitation payment each month. Next slide. Since 2001, Indonesia has decentralized its health system, and district hold the main responsibility of the providing most health-related services to the population. However, the share of the local budget of funding health services is relatively low, apart from paying salary and benefit. Most districts still rely heavily on the transfer fund from the the government to run their health program in terms of the immunization, vaccine, and vaccination logistic. Are directly provided by the central government, which constitute 77% of the total immunization expenditures. The operational cost is also partly supported by the transfer fund, with the little to moderate contribution from the local budget. In recent years, immunization has been included as one of the indicators as the minimal standard services that aim to assess the local government performance in providing the basic services. The new policy would benefit the program, service, and funding sustainability for the immunization in public setting. In addition, for the immunization services, national health insurance come to the form of the capitation fund to the conducted the primary care facility, both public and private. In Puskesmas, 60% of the fund is used to incentive health workers, and the remaining 40% to purchase medical supply and supported operational costs. In private facility, the capitation fund, they receive a slightly higher than the Puskesmas or health center, yeah. But there is no other source of funding apart from that. Next slide. Now we briefly discuss about the capitation funding from National Health Insurance. We call here BPJS. Yeah. Explained previously, each of the contracted primary care facility will receive a monthly basis, payment basis on the number of enrollment members. The fund cover generally medical consultation, examination, and the pharmaceutical, as well as the family planning and vaccination services. In the early year of the National Health Insurance implementation, Puskesmas were underutilized compared to the private clinic. Yeah. Data in 2016 show that the Puskesmas dominated the non-specialist referral rate to the secondary facilities, which resulted in increased healthcare costs. Therefore, since 2017 onward, BPJS National Health Insurance has been implemented pay for performance mechanism to improve the Puskesmas performance as a gatekeeper and simultaneously enabling efficient health system. The evaluation of the capitation funding had been based on the several pay for performance indicator, such as contact rates and members. There are 14%, including contact during the immunization services, non-specialist referral rate, 50%, and ratio of the control chronic disease about the 10%. Despite the consideration numbers of the private health facility and the fact that they can offer immunization services with the government supply vaccine, very few of them actually provide the services. And as described in the pie chart and bar graph, in the real condition, it is evident that the contracted public health care still being dominant in immunization services, 98% of all public health services, while only 50% of the all private healthcare provide immunization services. Next slide. On this occasion, we have the one district in East Lombok, a case study on how capitation fund has been mobilized, not only to the incentive the vaccination services, but also to support its operational incentive. For record, the East Lombok is one of the first two districts where the PCV introduced. PCV is the first new vaccine introduced in Indonesia in the transitional period of the Gavi support. Unlikely other new vaccine, PCV vaccine procurement is fully self-financed by the domestic funding, so no Gavi support. East Lombok has relatively highly targeted cohort that than other district and historically has high coverage performance. On the other hand, Puskesmas is in East Lombok is categorized as non-autonomy status, where the Puskesmas has no own authority to self-manage the total capitation fund they receive. The allocation fund is set by the major decrease based on the district health office proposal. As we can see here, a capitation fund as becoming one of the immunization source of where the district health office has successfully advocated the use of the capitation fund to procure vaccine carrier for about 125 units for 33 puskesmas in East Lombok. As at the puskesmas level, immunization activities are mostly funded by the OBOK fund, and we have found only few of the puskesmas has been able to mobilize capitation fund as additional resource to support capitation building for the immunization once new vaccine introduced in their district. Next slide. To recap here, there are four highlights in this presentation. First, GKN in Indonesian term, a fund of the capitation fund has been used to support immunization services, particularly at the health center or puskesmas. It covers not only the services fee, but also operational activities costs such as costs for outreach, training, and cold chain maintenance. While at the private clinic, capitation fund covers service fee and consumable. We acknowledge that this information was based on the analysis one of the district only. There is need to expand the analysis to a broader and more representative sample to map the pattern of the capitation use for the public health program at public health services across the province. Second, unlike the puskesmas, which is designed to provide the public health services, such as the immunization services, private clinic mainly focus on curative care. To date, the capitation payment is entitled to curative services, even though in fact it doesn't rule out the use of these fund to supplement the additional resource required for the preventive or public health program. And third, it is necessary to regulate the use of the capitation fund for promotive and preventive activities in both puskesmas and the private clinic. Finally, in the context of the Indonesian, which is the transitional of GAVI support, mobilizing the existing resource to ensure the sustainability of the program is critical. That can be support to you. Thank you.
Thank you very much, Paisik. This is a great example of really fully integrating immunization into a national health insurance system. And I think you've dealt well in Indonesia with two of the challenges. I think one is when you don't have 100% coverage, that you are able to offer free immunization services to everyone, whether or not they have coverage with the national health insurance scheme. And also to make sure that you have dedicated financing streams for the other components beyond individual immunization services to make sure that the whole program is fully funded and the funds reach where they're going. So thank you for sharing that experience. And I'm going to turn back to the panelists now with a few questions that came up for me as I was listening to all of you share this experience. And maybe I'll start with Tamar and Georgia, that you have all seems to be working quite well. It's not a traditional national health insurance system, but you are providing all of the functions in such a system and integrating immunization into that. And the one part where I heard that you had some challenges are creating incentives for private providers to engage in this. And so my question for you is, how important is that in Georgia to ensure access and coverage for immunization to fully engage private providers? Where do you see, and how much energy and extra effort do you think you need to put into finding the right incentives for them to engage?
Thank you for this question. It's really very important, given that in Georgia we have a vast majority of our providers are private providers, including village providers. They are independent practitioners contracted out by health service, by National Health Agency. But in fact, they are just private providers, and they really need to have adequate incentives to remain committed to the public health service delivery. It is very important, and what we do, it's again leadership by the National Center for Public Health and Disease Control, and this is about providing adequate information and emphasizing how important it is to have good coverage with immunization services, and how important the role of primary care providers in this process is. So in any case, primary care providers, they should understand that without providing essential public health services, universal coverage cannot be achieved, and then the whole importance and the sense of the UHC program can be undermined. That's why we do work with them to provide these messages, and to make sure that they remain committed to public health related services. And of course, while revising capitation payment, we are now working on revising capitation payment on for primary care providers, as well as introducing additional like mechanisms for keeping them motivated. It's important to define the realistic amount of payment, as well as to introduce some mechanisms which will stimulate like good performance in terms of implementing immunization services. So it's about providing good immunization related counseling, like before the time for immunization comes, and work with families, mothers, work with kids as well, and to build like good infrastructure for immunization. And this is something that we need to invest more on the state side, because again, private providers, they may not have interest and in investing immunization related infrastructure, and this is where the state again remains committed, and we provide investment to improve a cold chain, as well as to train primary care providers to keep their skills up to date. So I think these are mechanisms that we are using nowadays for keeping private providers closely engaged and interested in delivering immunization services. So this is like monetary and these are monetary and non-monetary as well, and support provided by the state programs, of course. Thank you. Over to you.
Thank you, Tamara. I think you raise a very important point, that when we are thinking about engaging private providers to deliver any public health related services, but especially immunization in our case, that is not just about incentives. It's not just about giving financial incentives to deliver more of this service, that there's a much more holistic approach that's needed to engage them. And that involves the education and the counseling and really understanding the public health aspects of it, but also the infrastructure, as you mentioned. And so it's a much bigger endeavor for them to engage. And so there is probably a lot more that needs to be done than just thinking about the incentives. And maybe I'll go to you, Asik, because there seemed to be a similar situation in Indonesia, that bringing in the private providers. And so there was a very low percentage of your service providers delivering immunization services that are private. And so the same question for you, what kind of work is being done to expand their participation, if you're feeling that is needed to maintain coverage in Indonesia, and how willing are they to go beyond just that individual service provision and really engage in the public health aspects?
Yeah, thank you. I think the case of the Indonesian is very interesting actually, because the immunization is fully covered by the government, especially with the central government. But meanwhile, we also have the minimum indicator in minimum standard of services that really this is mandatory, especially for the governor, for the mayor that have area in this area. So this is kind of the synergizing between the how we are mobilizing the target, because we are putting the target in the district as the performance of the major or the governor. This is really important for us. Meanwhile, the the central government actually they are providing like the yeah, of course, like the logistic for the vaccine and so on and so forth. That this is fully funded, and I know that so far there are still a lot of vaccine that we have it, but of course I know that this is how we are trying to mobilizing the for reaching like the covering more covering for the for the children. I know that this is one of the unique synergizing between the central government with the local government. Even now, I know that most of the health services actually have been decentralized, but some this really important thing like the immunization still under responsible for the central government, actually for the providing like the vaccine and for the coverage and operational. This is responsible for the the local government, especially for the district, and put it as the minimum standard for the coverage. So this is the unique one, I think. Thank you.
Thank you for that. And that again highlights when some parts of the immunization program are outside of the national health insurance system and funded and delivered by other parts of government. A high degree of cooperation is really needed, and especially in a highly decentralized setting like Indonesia, it's the national government and the local governments and the other agencies. Maybe I'll switch over now to you, Koko, and ask about Ghana. So you shared this experience of having preventive and public health services separate from your national health insurance system, which focuses on curative clinical services. And so you raised the possibility of integrating it into the health insurance system. But Ghana is in a situation where you don't quite yet have 100% coverage of all Ghanaians by the national health insurance scheme. So if you were to go in that direction and integrate immunization into NHIS, how would you ensure, is there discussion about how to ensure access and coverage for those who don't yet have coverage by NHIS?
Yeah, thank you very much, Cheryl, for that question. Yeah, there have been discussions. As I said, now currently, our NHIA basically by the Act focuses on clinical and curative services. So the whole discussion around how do we fund public health services, including immunization. Mind you, there in the law, there's some component of the funding that comes from the contribution and the revenue for NHIA that is used for what we call to support the government in terms of co-funding for vaccination. Okay, there are arguments and counter arguments here and there that if you say that the National Health Insurance is not funding immunization, they will tell you, what about the component of the NHI is supposedly about 10% that goes to fund co-funding for vaccination. But I think the most important thing that we need to be clear about is the fact that we need to make sure that not only the delivery of the vaccines, but the vaccines are able to reach communities for people to be vaccinated or for kids to be vaccinated. And that's an important thing. Somebody says that vaccines don't work by themselves, you know. So the whole delivery chain, the chain needs funding, which of course, in terms of even the providers to be able to raise revenue to provide the logistics that they need to fund their activities is very important. And I think that's what we need to do. So the whole discussion about the disconnect between public health, curative services, NHI, it's around the reform of our national health insurance policy and act, so that it can also include, you know, public health services, including immunization funding in the funding mechanism, so that you are not only focusing on curative services or clinical services, but you're also dealing with public health or immunization services. So that's where the discussion is going on. And that discussion is going on in terms of how do we make sure that we lower the bar a little bit for the amount of funding that goes for curative services and push that into public health services or immunization services. And that's where the discussion is going on. And I believe that, you know, if that is done with, that will actually support the delivery of the services, because Ghana, I mean, like rightly said by Dasuya and the minister, you know, in terms of Ghana, the participation of the private sector in this public endeavor is very limited, you know, because we have a very robust and a very good primary healthcare system. We have over 6,000 what we call the primary healthcare level providers in various parts of the country, 6,000 CHIPS compounds that we call them, with public health nurses, with community health nurses and volunteers who are providing these services. So reaching out to the population for us is not the challenge. The challenge actually is the delivery. And I think that's where we need to actually understand how do we make sure that the funding that goes for immunization or EPI services are funded through an NHIA. Working towards how do we also make sure that the majority of the people are registered and they are providing, you know, you have national insurance card that will allow them to be able to access services. Currently, like you rightly said, our coverage is below 40% of national coverage of NHI. And I think that's a challenge to immunization as well. Thank you.
Thank you so much, Coco. I think you raised a lot of really important points in there, but a couple to highlight. I think this idea that, this argument that if you're pooling together the funds for both public health services, prevention, curative services, then you can be more rational about how you allocate and how you prioritize public health and prevention. But if they're fragmented, you don't have that lever. I think that that's really a very, very important point. And the other point that you raised about, you know, when we talk about national health insurance, and some of the questions that have come up in the chat and the discussion board have asked this, when we talk about national health insurance, sometimes the discussion goes too far to the ideas around financing and the goals around financing and the mechanisms around financing, but service delivery is what is really most important at the end of the day. And so how do we look at these systems and these functions in a way that first and foremost support service delivery, and then figure out the right financing mechanisms to get behind them. We have just
I want to share just a minute. Sure. I want to just corroborate the point that was made earlier, which is very important, that in bringing the private sector to be able to participate in public health services in terms of immunization, and the point has really been made, and I just want to reiterate that not only incentives, but providing all the infrastructure for them to be able to function. Coaching equipment, make sure that we have the surveillance system that monitors what is going on there, give them incentives. The infrastructure is very important. And I think that is because there are communities that also, or areas that do not have public services, and therefore the private sector will be very important. That engagement is very important. What is also more important is that it should be cross-cutting in terms of making sure that we are not only focusing when it comes to immunization, but how does the private sector participate in other services also, you know, i.e. NCDs, for instance, screening, that also bring benefits to the population in terms of their engagement together to work with the public sector. I think that's also very important. I just want to reiterate that point and corroborate what my colleagues have said earlier. Thank you very much.
And thank you, Coco, for reminding us that although we're focusing on immunization today in this session, that these lessons apply to other public health services and other services that have both a public health and an individual health service dimension. So hopefully we can take some of these lessons and apply them there as well in other types of services. We just have 6 minutes left, so I'm going to do one last round of very quick inputs to ask from each of you on a question that's on my mind, and then we'll wrap up the session. But in Indonesia and Georgia, you're paying for these immunization services through capitation. And we know that sometimes capitation can lead providers to underprovide certain services. And so we want to make sure that that doesn't happen with immunization. On the other hand, in Ghana, we have that immunization is paid for directly out of the budget, but providers can earn some payments through national health insurance for other services that might be more lucrative for them. So there might be some crowding out or incentive to do other things other than immunization. So I just want to ask very quickly from each of the countries how the incentives that are coming through how you're paying for immunization services, do you think these incentives are helping to ensure access to immunization, or are there other things that might need to be done to balance the incentives to make sure that immunization is prioritized by providers? and public and private, or whoever you would like to focus on. So just maybe 1 minute each on that question, please. Maybe I'll start with you, Tamar.
So thanks again, Cheryl. It's really very important question, and we do realize here that in incentives, there should be more incentives for primary care providers to prioritize immunization coverage. Also in Georgia, we observe quite high coverage with immunization services. However, with competing priorities like we experience nowadays with COVID pandemic and with some other responsibilities, which could be more attractive for private providers, it's really important to focus more on finding the ways for introducing like really attractive payment system to make sure that we have sustainable immunization, we sustain immunization coverage, and we do not experience any interruption related to any other factors. So yes, this is something we need to take a closer look and to upgrade our system with more incentives for primary care providers for immunization services. This is how I feel. Thank you.
Thank you, Tamar. Patsy, do you have a final thought on that question, or other final thoughts that you would like to share in the last minute? You are muted. There you go.
Thank you. I think for the Indonesia, actually, because we have first is from the national insurance that also provided for the capitation. I know that is really really important, especially for the supporting for the operational, like how we reaching the filter operational, and the others. We are also have a kind of the minimum standard of services that really mandatory for the local government, and immunization one of them. I think this is from the how managing board for this one. I think really will have the incentive actually from the local government. I know that this is really important when we are come into the evaluation for the minimum standard for the services that will conducted in every year. I know that if this is okay, I know that it will be increasing for the coverage, and it will become one of the model of the sustainability for the future. Thank you.
Thank you so much. And last word, Koku, just very quickly, any thoughts on that last question?
I think that incentives are very important, and there's no doubt in my mind that they need to be improved. But incentives might not only be seen in terms of monetary, but also in terms of community engagement, in terms of recognition. I mean, so that you don't only monetize the incentives nature of support, but also make sure that the people who are supporting your volunteers, the private sector, the service provider themselves have a high appreciation of and the public recognition. I think what is also very important is the advocacy and education for people to understand the benefits of immunization, and therefore those who collaborate with the incentive system that are put in place. But definitely it's an important area that we need to focus on as well.
Thank you so much for these last thoughts. This is a fantastic session. Thank you all. I'm going to have 3 quick main messages that I took away. The first one is that universal health coverage requires these functions to be in place to raise revenue, to pool it, to purchase services and provide them. But labels should not matter. It's getting the right functions in place for your country context. And Georgia is a very good example of mixing and matching these functions to get the most benefit, and not necessarily putting a national health insurance label on it. We heard about all of the risks associated with fragmentation, fragmenting populations who might not be in your UHC or your national health insurance system and may not have access to immunization services, fragmenting services, public health and preventive versus curative. And I thought we heard some really great examples in all of the countries how to try to manage that, how to make sure that fragmentation does not lead to people falling through the cracks and not getting immunization services. And finally, this last discussion on incentives, I took away that incentives are really not the main issue. They are important, But we need to make sure that the infrastructure is in place, that the information, education is in place, flexibility for providers to use their funds well, and then get the right incentives also. But that isn't the most important part of all of this. So thank you so much to everyone for your wonderful contributions and this great session.
Thank you.